and 2 inches posterior to the as is. Okay. I used to not even do my fingers. From a lateral, I just move the patient half an inch down and then 2 inches away from me. All right, here, suspend respiration. So just have them hold their breath. Now, if you don't have support, males, you can do a caudal angle of about 5 degrees. Do you guys go perpendicular on yours, or are you guys actually doing an angulation?
Angulation.
Perpendicular. Okay. Angle. Okay.
Perpendicular angle.
Okay. See, this is what I'm talking about. So you're going to be shown different ways of how to do the same thing. But you're not going to be tested on what they tell you. You're going to be tested on what's up here. Okay? So you got to block out what they've shown you and know this. Okay, guys? Same thing at the end of the program. What is it? About a year from now? Woo! You guys completed a year.
Yeah, but
A year from now, okay, when you guys get ready for your boards,
We're gonna be messed
you
up.
gotta forget everything that they taught you in the hospital and go with what we taught you here on campus. And this is why Mr. Siegel is great at what he does. If you guys haven't had any courses, if you haven't taken any courses with Mr. Siegel, the epitome of OCD. Okay? He is great at what he does. And I know it's going to sound monotonous when he comes visit you guys, but what he's trying to do is making sure that you guys don't forget what we taught you here. So by the time you take your boards, it's going to be fresh in your mind. He's going to make sure you guys still remember all this. So when he visits you, he's going to be going over procedures. And then he's going to take his book and he's going to go with all the different angles so you don't forget it. Okay. Did I tell you guys 100% pass rate on the last class? We also have 100% employment.
Last 2
Did
years.
Miss tell you guys that?
For last couple years, she said 100%.
Well, this year we have 100%. The last year's graduation, 100% employment.
Awesome.
Yep.
That's great.
It's exciting.
And inspiring too.
I'm just curious. So for those at Kaiser who are what job did those students end up working at?
McDonald's?
What job? Well, one of them actually. Well, I can only think of one right now. He works in another Kaiser facility. Actually, there's another one who worked at a Kaiser facility that works in Kaiser. What they do is they had their foot in the door in another Kaiser site, so that when they finished the program, they were already in the system. That's kind of how they did it. Yeah. Now, another one of my Kaiser students, she got a job in an outpatient facility. And I said, don't you want to work in the hospital? She goes, I don't want to do inpatient. She goes, I just want to do outpatient. So she ended up in an outpatient facility.
But she still worked already as someone else at Kaiser, right? To get her foot through the door. Oh.
Yeah. So all the Kaisers, they have jobs too. May not be at Kaiser, but they have it somewhere else. The job market out there is excellent, guys.
Awesome.
Yeah, it's excellent.
Phew.
Okay, what were we talking about?
Food.
That's fine, okay. All right, so this is your spot film. So if there is no support with, there's no support with hip tilt, then you're gonna do one of these. 5-degree angulation caudally for males and 8-degree caudally for females. Okay. So again, the key here is to match the interiliac line between 5 to 8 degrees. So you're not just looking at the area of L5-S1. You want to make sure, again, you've got adjacent structures. Okay? So L4, 5, and S1 are going to be demonstrated with L5-S1 joint open. Collimate to small area. Even when I use a spot film of 9x9, I was collimated to an area of maybe 3x3 or 4x4. This is all you need. Okay? It's also I had a lot of confidence in my work.
Mm.
And I always got it right there in the middle. Okay. Now, if you guys are opening it up to 14 by 17, that's no confidence. You guys are laughing because you've probably seen techs do that, right? Wide open.
Some of them would open more if the size of cassette allowed, or
Yeah.
yeah, full
I
body
know.
scan.
They didn't go to Cyprus. Okay. AP axial of L5S1. Patient is supine. Put something underneath their legs to open up that curvature a little bit. Central ray is going to be directed 30 to 35 degrees cephalad, entering at the level of as is in your mid-sagittal plane. Again, do we need a big field or do we need just a small field? We're just looking at the space, right? So a small field. But here's the key. You don't want to collimate too tightly from side to side because we want to include what? SI joints. We want to include the SI joints. Okay? This is a special projection. They don't do it all the time. It's only a special order. It's not part of the routine. Okay, scoliosis series. So any questions about the lumbar series? Okay, scoliosis series. I'm going to try to fly through this as quickly as I can. How many guys have scoliosis units at your facility? Okay, do they look anything like that? Where you got the breast shields and the testicular shields?
No.
No? Okay.
It just like opens, almost looking like a wardrobe. You open it and put the two cassettes.
Well, like it kind of serves two purposes. Not only is it supposed, these breast shields are not only supposed to protect the breast, but also it kind of helps collimate the area of interest, giving you a high resolution type of radiograph. So usually you're going to do two projections, one where the patient is laying down, and then we do stress views to see what happens when they're standing up. Okay, so usually two, one laying down, one upright. And they also prefer that you do it PA for lower doses. Now, for those of you who have done scoliosis series, they're probably not doing it PA, they're doing it AP, again, for convenience. Okay, so two, one laying down, one up. You're going to open up your collimated field to the full length, of your image receptor. And the bottom edge of your image receptor or your light field is going to be approximately 1 to 2 inches below the iliac crest. Okay, so we want to go 1 to 2 inches below the iliac crest. Okay, mid-sagittal plane, and then 1 to 2 inches below the iliac crest, done on expiration. So again, one laying down, one upright. Okay? So we're looking at the thoracolumbar region, and you will see here that the image receptor, the bottom of the image receptor, or the image here, is 1 to 2 inches below the crest. Okay, done on expiration. Collimate to the area of interest. You don't need a large field. Okay, and some of these you will also notice that in these pictures, if they're females, you will see the underwiring of the bra. Why is that? Do we care? Are we actually looking at the bony structure, or are we just looking at the alignment? We're just looking at the alignment. So you may find that a lot of these thoracolumbar studies or scoliosis series, you will find artifact in there, which is acceptable. Because again, they're just looking for alignment. Okay. Lateral position. You're going to place your patient in a true lateral position. Again, centroid is going to be at the mid-coronal plane, making sure that the bottom of the imaging field is, again, 1 to 2 inches below the crest. Now, can we do either left or right side?
Yeah.
You can, okay? But pay attention, look at your AP. Okay, look at your AP. If there is some scoliosis with a curve, you want to put the convex of the spine closer to the image receptor. Okay, so if there's a convex of the spine, you're going to place that closest to the image receptor. Okay, any questions there? You know what's funny, every time I see this picture, and this is just me, Martha's way over there, collimated right here. Yeah, oops. All right, so thoracolumbar spine is demonstrated. Again, you will see that not so much in this image, well, kind of, here's the crest. 1 to 2 inches below the crest. Okay. It demonstrates spondylolisthesis. What is that? Remember, that's the slipping of the vertebral body due to the underdevelopment or condition of the pars interarticularis. And it also demonstrates the degree of kyphosis and lordosis. And there's a reason why I put this here, because it's probably going to be where? A test. All right, the Ferguson's method of the scoliosis series. 2 upright images are going to be taken. 2 upright images are going to be taken. One will be just a regular PA or AP of the spine. Same context applies. Open up your field light to the length of the image receptor with the bottom of the field light or the image receptor 1 to 2 inches below the crest. So this is the first one is just your normal AP or PA shot. Okay. So the second shot now will be placing a support on the convex side, of the spine. Okay, so underneath the foot. It says here that if they can't stand up and they're sitting down, you're going to place the support under the butt side that has the convex side. And this differentiates between the deforming curve and the natural curve of the body. That's your compensatory. Remember your compensatory curves you were talking about? That's the natural curves that you're born with and later develop when you get older. Okay, that's the normal curve. That's what it's referring to, the compensatory curves. Okay, so thoracolumbar spine demonstrated. Vertebral column is centered 1 to 2 inches below the crest is also going to be demonstrated. Here we have, again, the underwirings of the broad. And that's okay because we're just looking at the alignment. Okay. And then we have our AP right and left bending. This is going to be a little bit different here. I mean, everything stays the same. The only thing that's going to be different here is instead of collimating side to side, you're going to leave it wide open to the size of your image receptor because of their angle. The angle that may take the full size of the image receptor. You don't want to cut anything off. Okay. So the right and left bending, you're going to use your pelvis. The pelvis has to stay in midline with the table or midline with the wall bucky, and they're going to bend without the pelvis leaving that mid plane. So the pelvis is going to remain as the fulcrum. Two images for comparison, left and right bending. Okay. So we have the image, the field light opened up from side to side because the way they're bending, we don't want to cut anything off. And then we also have in the lateral where they're hyperflexing and hyperextending. Again, two images are necessary. Keeping the pelvis in, using the pelvis as a fulcrum while they flex and extend. So same criteria stays the same. Include the bottom part of the image receptor 1 and 2 inches below the crest, okay, and at the mid-coronal plane. The pelvis of the hyperflexion and hyperextension demonstrates mobility at the fusion site. So although it says scoliosis, part of the scoliosis series, this actually evaluates those who have had a lumbar fusion. All right. Any questions? I thought we were done. Okay, the sacrum and the coccyx. For the sacrum, we're going to do a cephalic tube angle, whereas the coccyx, we're going to do an inferior tube angle because of the curvature of the sacrum and the curvature of the coccyx. Those angulations will put the sacrum or the coccyx in true profile on the image. Here are some elements that you guys need to be familiar with when we are taking x-rays of the sacrum and coccyx. It's different from anything else in that the criteria is you want to make sure that your patient empties their bowels, empties their bladder before you take these shots. Because yes, we are looking at the bony definition of those bones, and we don't want any fecal material or gas patterns that may interfere with the diagnosis. So we want to make sure that they're empty. Okay. So for an AP axial sacrum, the central ray is 15 degrees towards the head, 20 degrees for greater posterior curvature. That usually applies to the females. Central ray is going to be midway between the symphysis pubis and the as-is. So are we going to palpate for the symphysis pubis? Mm-hmm. What other bony anatomy can we use?
Greater trochanter.
Okay, the greater trochanter of the femur. Okay, so the greater trochanter of the femur and the as-is going to be your landmarks. So in between there. Collimate to an area of, again, maybe 4 by 4, 5 by 5. We don't need a lot. We're just looking at the sacrum. Okay. When you open up your field, you want to include your SI joints. You want to include your SI joints. Okay? And this puts the sacrum in true profile. Okay? But look what happens to the angulation. What are we missing here? We've got the sacrum, but look at where the coccyx is located.
It's superimposed by
Superimposed, but do we care? No, because we're looking at the sacrum. So we don't care about that. But now if we wanted to look at that, now we're going to do the reverse angle, right? We're going to do the reverse angle. So for the coccyx, angle is going to be 10 degrees towards the feet, so caudally, 15 degrees for a greater curvature. Central ray is 2 inches superior to the symphysis pubis, or 2 inches above the iliac crest. I mean the greater trochanter. Okay. Collimate, 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 collimate. We don't need a lot of field light or field for this X-ray. And now you will notice that with this angulation, the downward projection through the symphysis pubis away. So the symphysis pubis is down here now. It projects it away from the tailbone or the coccyx. Okay? Because the tailbone, look how small the tailbone is. If there was any fecal material in the colon or the rectum, gas patterns, it'd be difficult to see the anatomy. Okay? So do we also need to include the SI joints? I'm answering myself again. Yes. Okay. Any questions so far? Am I going too fast? No. I can slow down. Go slower? No. All right, lateral sacrum and coccyx. I think we're closing it up, right? I think we're almost there. Okay. Lateral sacrum and coccyx. Central ray, 3 to 4 inches. Oh, so first of all, put them in true lateral. Okay. Back is straight. Iliacs are perpendicular. Okay. Back straight, perpendicular. Center 3 to 4 inches. Posterior to the as is. This is centering for the sacrum. And again, if possible, use a lead strip. Collimate to the area of interest. Okay, we don't need a lot of field. So this is for the sacrum. True lateral is demonstrated by the greater sciatic notches are superimposed. So these notches, this whole superimposition, that's how you got true lateral. And see, again, especially when you're shooting through the hips, we need really, really good tight collimation. Otherwise, we're going to lose some of that contrast.
So, like on this image, they're not really superimposed, right?
They are. They don't look superimposed because, again, because of the divergent beam is kind of throwing it off.
Okay, so if I see it like that,
Then that's
I shouldn't doubt my position.
No, do not doubt yourself. Don't doubt yourself. All right, lateral coccyx. Again, true lateral, back straight. Iliacs, perpendicular. Central ray, 3 to 4 inches posterior, and 2 inches distal to the as-is. 3 to 4 inches posterior and 2 inches distal to the as-is. Requires lower KV and mass than the sacrum. Okay, because we're no longer shooting through the hip, we're just shooting through butt cheeks, soft tissue. Okay, not only that, it's a smaller bone. We don't want to, what do we say? We don't want to overexpose or burn out the tailbone. Very, very small. It's not very dense at all. Okay, so tight collimation. Coccyx with open segment interspaces, if not fused. No rotation. Again, we're looking at the greater sciatic notches. Collimate, collimate, collimate. We're done. I'm done. You guys can go through this. What's wrong with this? Everything. Okay, let's just okay, look. 5, 4, 3, 2, oops. One is cut off, right? We want to see the spinous process. Well, you know what's wrong. No need. Okay. Lateral scoliosis. I mean, we're down here at this. This is a male. We're down here at his,
What?
his goodies. We're too low. We're too low on this one. So centering is low. You guys agree?
Yes.
What else are we doing? We're cutting off. Yeah, it's the thorax and lumbar. We're missing part of the thorax. Okay.
KV is too high.
Okay, well, let's forget about the KV. What about centering? Okay, so we're missing again the posterior part of the spine, right? So we're missing all the spinous process. Identify the most. 5, 4, 3, 1.
SI joints?
Yeah, SI joints.
SI joints? Otherwise, I would have said it's okay. All right. All right. Alright guys, so I'll see you guys in a couple hours. Be safe. Be there at 4:30. Okay? Park Plaza, 3 levels on up. Meet at the doors farthest to the left by the fountain. Right? Do we got it?
Yes.
We got it. And everybody submitted their permission slip. Everybody's got a map.
Sure. Well, don't know.
All right, guys, go have fun, and I'll see you guys in a couple hours. Okay.
It's gonna be actually. Oh wait, let me say it.
Brad? Nope. Really?
So proud.
You know, I don't either.
Are you ready for like long ride, bro?
Be a long road trip.
I also want to know what it's different. We don't care, but like. Sarah. Yeah, if you're ready to come for that, I'll be ready about that because I'm only taking.
Go home. Are you gonna go home? I don't know.
Guys, we're gonna go to Heroes. It's in Fullerton. It's right on Harbor.
Where are we going?
Heroes.
Oh, we're going right now, right?
Free food and nothing else.
Nothing else.
Sarah, do they have desserts?
Great food and nothing else.
Hospital, they have a lot of disinfectants and like. So maybe they're like the ones that. Oh, it's the ones from Marco. Oh, I didn't say anything.